Good morning, everyone, and welcome to this week's Urology Breakfast Webinar. This morning, we'll be focusing on an important area in urological oncology, both covering premalignant disease as well as surgical management of penile cancer. So our first speaker is Dr. Aldrin Haruzivi. Dr. Haruzivi will be speaking on premalignant lesions of the penis, bladder, and prostate. We know that premalignant lesions represent an important opportunity for early diagnosis and intervention before progression to invasive malignancy. So recognizing these lesions and understanding their natural history as knowing when to and how to intervene are essential aspects for the modern neurological practice. This talk will provide us with a practical overview of the key premalignant conditions affecting the penis, bladder, and prostate, as well as highlighting the clinical features, risk factors, and diagnostic considerations for management strategies that every urologist should be familiar with. So, Aldrin, thank you for joining us, and we look forward to your presentation. You can share your slides.
Thank you, Aman. Can you see my slides?
We can, yes, you can proceed.
Okay, thank you. So I'm I'm Aldrin Haruzivi. I'll be speaking of premalignant lesions of the penis, bladder, and prostate. So in outline, I will speak of the penile premalignancies first, and then go to the urinary bladder, prostate, and then we conclude. So with regards to the penile lesions, these are premalignant lesions which have a potential to progress to invasive penile squamous cell carcinoma, and the most important are grouped under penile intraepithelial neoplasia. And it's important to recognize these lesions early, and treatment will help to reduce progression to invasive squamous cell carcinoma. So with penile intraepithelial neoplasia, these are characterized by penile squamous epithelium with dysplastic changes and an intact basement membrane. They are precursor lesions to invasive squamous cell carcinoma, which, if left untreated, they can result from the literature, it says up to 10%, but other reports of 30% progression to squamous cell carcinoma. So broadly, just like their counterparts, the carcinomas themselves, they are categorized into two groups according to association with the human papilloma virus, HPV. So we have the HPV-associated ones and the HPV-independent penile intraepithelial neoplasia. Of note is that on the WHO 2002 edition, there were terms that used to be used, such as carcinoma in situ, Bowen's disease, erythroplasia of Curette, and Bowenoid papillosis. So just to mention, erythroplasia of Curette, it involves the glands and prepuce, whereas Bowen's disease involves the pineal shaft and the rest of the perineal region. But these terms are now discouraged, as it clinically is important, but it doesn't really help so much in terms of your management. With HPV itself, it is recognized as the main risk factor for penile cancer, and the virus has about 118 genotypes which have been identified, and 40 of those involve the genital tract. Of those 44, which is type 6, 11, 42, and 44, they are associated with gross condylomata and low-grade dysplasia. However, especially type 16 and 18, they have a higher association with malignant disease. So these are termed the high-risk HPV genotypes. So genital condyloma, venereal warts, genital warts, and genital HPV infection, these are all terms which encompass HPV infection. And although they are not, in essence, termed as the other sexually transmitted diseases, they are actually, HPV is actually a sexually transmitted disease. And histologically, a coilocyte, which is a cell characterized by an empty cavity surrounding an atypical nucleus is a pathognomic feature for HPV infection. The tumor virus itself is important proteins, especially from type 16 and 18, which are the high-risk viruses. They produce particularly E6 and E7 proteins, which target tumor suppressor genes, the retinoblastoma protein and protein TP53. And these are what results in carcinogenesis when they are affected. So P53 is responsible for apoptosis and DNA repair mechanisms. So if that is disrupted, then you don't get apoptosis when errors occur during DNA replication. And the retinoblastoma protein is involved in the cell cycle control itself. So once again, if it's mutated, then you have unregulated cell cycles. So progression to invasive squamous cell carcinoma happens in about 5 to 33% of cases if HPV is not treated. Of note, especially in our setting, we have HIV infection, which may predispose affected patients to rapid development of squamous carcinoma. So these are patients who already have pre-existing HPV infection, but because now they have, on top of that HIV infection, which leads them to be immunocompromised, their progression to squamous cell carcinoma is faster. And of note is even in patients who are on ART treatment, who are virally suppressed, that progression doesn't seem to be affected by the fact that their viral load is suppressed. So it's important to note that in HIV-infected patients, regardless of their response to the treatment, they can easily develop squamous cell carcinoma. And about 50% of penile cancers are associated with HPV. So this is just a diagram to help understand for those who like pictures, what I was just explaining. So you have HPV infection and the DNA from the HPV is integrated into the host DNA of the basal cells. Then we have the two important proteins that we mentioned earlier, E6 and E7, whereby E6 affects P53 and E7 affects the retinoblastoma. So the combination of the two, and also remembering that these infections are ongoing, so it's a chronic cycle. So there's infection, reinfection, accumulation of these mutations, and then subsequently, if they are untreated, you end up with penile cancer. So as we mentioned earlier, these two grouped in two main groups, which is HPV associated and the HPV independent. So with the HPV associated penile epithelial neoplasia, we have dysplastic squamous epithelium with an intact basement membrane. And these conditions, they contribute more than 3/4 of all penile intraepithelial neoplasia cases. And again, they are subgrouped into two main groups, the basaloid subtype and the warty subtype. However, sometimes if lesions with mixed appearance, with both basaloid features at the base and warty features in the superficial layers, and these ones, they are the mixed subtype, or they can be designated as warty basaloid, which just shows they are both both subtypes are involved. And the penile intraepithelial neoplasia themselves, they are graded into two groups, group 1, 2, and 3, depending on the degree of cytological atypia. But only group 3, which is the high grade, is what is reported by pathologists, and that's what you get on your report. Another type of HPV associated is a giant condyloma acuminatum, which we can see on the picture in the bottom corner. This was initially described in 1925 by Lowenstein and Buschke, and then later again by Lowenstein in 1939. And the tumor itself displaces and destroys adjacent structures by compression. So it's a locally advanced tumor, but it does not usually metastasize. And it's associated with HPV 6 and 11, which are two of the low risk HPV genotypes. And like I said, there is usually risk of malignant transformation, and this is reported up to 56% in some case reports. Treatment-wise, surgical excision is what is recommended, but some recent studies have shown use of systemic interferon and laser to be effective. Of note is that topicals, which we usually use, they are ineffective, and also radiotherapy is ineffective against these tumors. Going on to the non-HPV related intraepithelial neoplasias, this is when you have dysplastic squamous epithelium primarily confined to the basal and parabasal cells within an otherwise well-differentiated epithelium and an intact basement membrane. They are associated with usually older men in the background of chronic inflammation, especially with relation to lichen sclerosis. So speaking of lichen sclerosis, which is also called balanitis xerotica obliterans, the genital variation of the lichen sclerosis, and it manifests as a white patch on the prepuce or glans. It's most common in uncircumcised middle-aged men, and it's a frequent finding in conjunction with squamous penile cancer noted in up to 50% of patients. Of note is also that there is a latency period between treatment of lichen sclerosis itself and carcinoma development. Some reports show a latency period of up to 17 years. So someone was treated more than 17 years ago, and then now they develop squamous cell carcinoma. Treatment-wise, you have clobetasol propionate cream, which you apply from 2 to 3 months. Of note is because of the location of these lesions, you usually get meatal stenosis, which may require repeated dilatations, corticoid injection, or even formal reconstructive surgery to treat them. Another HPV independent lesion is a cutaneous one, as we can see on the picture on the glands. So these are rare lesions with less than 100 cases reported. However, there are some predisposing factors which have been identified. First of all, they occur on a already pre-existing skin lesion, and there is some trauma to that area, or just because of poor hygiene. And they are characterized by an overgrowth and conification of the epithelium, and it actually appears like the animal horn that we know of. And the actual horn itself is not what's important, but what's under the horn is what we are worried about. And this may be benign lesions under the horn. So when we have seborrheic keratosis or viral warts, it can be premalignant, such as in Bowen's disease, and can also be malignant. So squamous cell carcinoma is noted in up to 33% of these penile horns, and treatment-wise, surgical excision with a margin of normal tissue about 5 millimeters above the base of the horn. Another non-associated from HPV is leukoplakia, which is the incidence of carcinoma from this is actually not known, but it's common in diabetic patients who are usually unable to retract their foreskin, and they usually have poor hygiene, so you end up with chronic inflammation. So they are associated with plastic changes in up to 20% of the cases, which is why we are worried that those dysplasia will end up resulting in carcinoma. Treatment-wise, surgical excision. The last one is pseudo epitheliomatous keratotic and micaceous balanitis, which is again a rare lesion which occurs in 4 main stages. We have the initial plaque, the late tumor stage, verrucous carcinoma, and invasive squamous cell carcinoma. Treatment-wise depends on which stage you catch the tumor at. So there are topical and surgical incisions that you can do. All in all, when I looked at some data, most of the studies, like I said, this is a rare condition. Penile cancer itself is already rare in most developed countries, a little bit common in our setting. So there was this study that I found, diagnosis and management of pre-malignant penile lesions. And they know that majority of our knowledge is based just on small, non-randomized retrospective studies due to the fact that we don't have a lot of cases to go by. And in some centers, they have specialized units which help to manage the conditions. So with treatment, before we speak of that treatment, I think it's worth noting that there is an HPV vaccine which is available. So there's quadrivalent and nanovalent, can be given. Usually the age is about 11 to 12 years, but you can start at 9 years until 26 years. It's usually, depending on which age you give, it's 2 or 3 doses. And there's also circumcision, which we know confers benefit if it's done, especially in the infancy period. But when you have the lesions themselves, you can use topical treatment, including podophyllin, imiquimod, 5-fluorouracil or trichloroacetic acid. And as surgeons, you can also do surgical excision. With the excision, there are different ways depending on where the lesion is. You try by all means to offer organ preserving surgical care. So there is glanectomy or resurfacing techniques. You can involve the surgical plastic reconstructive surgeons to help in case the lesion is so big that the defect needs reconstruction. Other modalities that are available include cryotherapy, laser, and of late interferons, which also help to manage this. Moving on to pre-malignant bladder lesions. Again, our knowledge of these lesions have been progressing over the years. Started with classification, which was done in 1998. And we have 2 major groups, which are the papillary and the flat lesions, of which the flat ones are usually the pre-malignant lesions. So in 2004, WHO modified these classifications, and most of these carcinomas are now grouped in 5 or so different stage groups. Of note is that, again, pre-malignant lesions of the bladder may progress to malignance over time, and although they look benign, they harbor genetic changes that signify their malignant potential. And some of the lesions may look like they are carcinoma, and if not properly diagnosed, they could result in serious over-treatment. So with pathogenesis, like I mentioned just now, there is some chromosomal links. So we have long arms of chromosome 9 and 14 and 8, of which if the mutation is on chromosome 9, they result in genetically stable pre-malignant and low-grade malignant tumors. But those which involve chromosome 14 and 8, they are genetically unstable. And correct identification of these tumors avoids over-treatment and leads to appropriate follow-up. So like I mentioned, the main classifications involve the flat and papillary urothelial hyperplasia, reactive atypia, atypia of unknown significance, and urothelial dysplasia according to WHO. But there are other classifications that I also found useful that I will go through, which include intestinal metaplasia, keratinizing squamous metaplasia, and verrucous squamous hyperplasia. Starting with the flat urothelial hyperplasia, this is when you have markedly thickened urothelium without papillation. So the mucosa can be thickened to up to 10 or more cell layers. There is no cytologic atypia, but this are associated with low-grade neoplasia with a 5-year risk of developing urothelial neoplasia up to 48% in those who have prior history of urothelial malignancy, or 27% without prior history of malignancy. So close follow-up is warranted in these cases. moving to the papillary ones, they are common in the older males with a strong temporal association with papillary urothelial carcinoma. And the mutations are linked with chromosome 9, the long arm of that chromosome. And like I said, the 5-year risk is about 48% with prior malignancy and 27% without prior malignancy. So we can see on the picture, you have the papillary hyperplasia without any dysplasia happening. Then you have verrucous squamous hyperplasia, which is a rare lesion, common again in adult males. You have hyperkeratosis and parakeratosis, as you can see on the darkened part of the picture. And they superficially resemble verrucous carcinoma. However, they lack the characteristic invasiveness of the verrucous carcinoma tumor itself. They are associated with squamous cell carcinoma of the urinary bladder. The next lesion that we get is reactive atypia, which is characterized by nuclear abnormalities in the background of an inflamed urothelium. So you have history of chronic inflammation or reaction from some noxious stimuli. And most of these patients will have irritative voiding symptoms. Endoscopically, on cystoscopy, you'll see edematous and inflamed appearing bladder mucosa. But microscopically, the cells, they have the normal progression from basal to superficial cell types. So it does not independently evolve into carcinoma. However, there is pre-existing dysplasia, and this may mandate rigorous investigation. When you have urothelial atypia of unknown significance, it's because you have unclear changes that you can see whether they are pre-malignant. The pathologists will not be able to say with certainty that they are pre-malignant or they are just reactive. So they say it's of unknown significance, and you can use immunohistochemical staining to differentiate them from dysplasia. And again, this one does not independently appear to lead to carcinoma, but it's of not, because if it's pre-malignant, then later on you may have carcinoma developing. Then urothelial dysplasia itself, it's a flat lesion with cellular atypia less than that seen in carcinoma in situ, which makes it pre-malignant. So you have normal urothelial thickness with altered cytologic appearance, and genetically they are unstable, and staining will help to show the dysplastic cells. So there is 20% chance of progression to carcinoma in situ in primary lesions and 60% in those with prior history of bladder cancer. The last identified one is intestinal metaplasia, which when you have glandular metaplastic lesions where they actually resemble the intestinal epithelium histologically, and they are precursors to development of adenocarcinoma. Keratinizing squamous metaplasia is very rare, but it's something which is associated with squamous cell carcinoma. So you have urothelium being replaced by stratified squamous epithelium, hence the link with squamous cell carcinoma of the bladder. The last group is the premalignant prostate lesions. There are two major groups. The first one being high-grade prostatic intraepithelial neoplasia. These are architecturally, they look benign, and however, cytologically, they have atypical cells. So you have their basement membrane remains intact, so it's non-invasive, and they're subclassified as low-grade or high-grade. But again, only the high grade is what we normally get reported. And they are considered as the most significant precursors of prostate adenocarcinoma. And in some literature, they say if it's detected on prostate biopsy in elderly patients after transurethral resection, usually there is no follow-up required. Because in itself, high-grade prostatic intraepithelial neoplasia increases with age. with up to 70% chance of getting it in those who are above 70 years of age. Mean risk of cancer detection on subsequent biopsy after high-grade intraepithelial neoplasia within a year is not significantly higher than the risk in those we had a biopsy after a benign diagnosis. Hence, when you have unifocal high-grade prostatic intraepithelial neoplasia, you don't really need to repeat the biopsy unless there are other clinical indications that point towards cancer. But if you have neoplasia, intraepithelial neoplasia in 2 or more cores, you need to do some further investigations or close follow-up, even repeat biopsy, because it may be just you sampled the atypical cells, but around it there is actually carcinoma there. So in younger patients, a more aggressive workup is required to rule out clinically significant tumors. Moving on to atypical small acina proliferation. These are suspicious glands, insufficient for definitive cancer diagnosis. They are detected in less than 5% of prostate biopsies, and they are not truly premalignant, but associated with a high likelihood of missed adjacent carcinoma. So when you repeat biopsies in ASAP, you actually get up to 60% of positive adenocarcinoma, with 12% of those being clinically significant. So with ASAP, repeat biopsy is recommended. So in conclusion, premalignant conditions of the penis, bladder, and prostate, they may never regress if not addressed, but because of the rare presentations of these, we don't have standardized follow-up regimens, but it is necessary to recognize them and institute appropriate management plans. And a multidisciplinary collaboration with pathologists is important. As we have noted, most of the lesions, either they appear like carcinoma or they have certain features that need some special investigations to be sure what they are. So if you collaborate with your pathologist, you will be able to identify them correctly and institute appropriate treatment. Thank you for your attention.
Thank you, Alden, for your talk. Do you have any questions from the floor? We've got a question from Dr. Rode.
Alden, thanks for the talk, man. It was really insightful. Alden, I just wanted to ask you spoke about sort of penile preserving strategies, and then you mentioned Mohs and glans resurfacing. I'd just be interested. Sorry, I get confused sometimes. What's the difference between the two? Do you know? Or can you maybe just tell us what's Mohs and glans resurfacing and when you choose one over the other?
Thank you, Dr. Roth, for the question. I actually saw Mohs, but I actually didn't look at what exactly it entails. So apologies for that. I can't tell the difference between the two. But the glans resurfacing strategy is when you have lesions on the glans penis. So usually what happens is you excise the lesion in full, but then the resurfacing part of it is they take like a graft to, because there will be a big defect. So just for the cosmesis of whatever you have done, you put a graft on that defect. But I can't tell the difference because I didn't look at the other one.
Thank you, Alden. We have another question from Prof. Laz.
Thanks, Alden. Nice, clear and comprehensive talk. I think that you made some comments about HPV, and it's quite common in our community and something one needs to know a fair bit about. I've sort of learned a few things recently which have been important things that I didn't know about managing these patients. The one is that even if the patient had HPV in the past, they still remain infectious to their partner, even if there are no visible warts. And that's has a huge implication for patients, as you can imagine. So that's something that you will see in the books. The second thing is patients will ask, should they get the vaccine if they've in fact had HPV and been treated for that? It would appear to be not of much help because you've already had the disease, so why give the vaccine? But it turns out you should still give HPV patients the vaccine. The reason being that the vaccine is particularly targeted at the serotypes that don't cause the warts so much as cause the cancer. So it's still recommended to give the vaccine, the Gardasil 9. If I can just expand on what I think is quite a landmark paper related to HIV and HPV co-infection. South Africa would appear to be an ideal place to investigate such a thing. And the colleagues at Universitas Hospital, University of Free State, under Schalk Wenzel's leadership, wrote a paper on that. And I think it's just worth reflecting on the conclusions because I think it's really an important thing to know about. They wrote that patients with penile carcinoma had a higher prevalence of HIV infection. I think that's relatively self-evident. But the HIV positive group was significantly younger at presentation, which is interesting, and had a higher prevalence of HPV infection, suggesting that HIV may contribute to HPV-associated penile cancer in younger patients. So I think quite a landmark paper from their work. Thanks.
Thank you, Prof.
Good. Any other questions on the floor? I don't think we have any questions in the chat. Thank you, Alderman, for an excellent talk. We'll move over to the next presenter. So our second speaker this morning is Dr. Groote Chacha. He's one of the urology registrars at UKZN. Dr. Chacha will be presenting on penile cancer, lymph node surgical anatomy, as well as management. So we know that penile cancer remains a relatively uncommon malignancy, but it presents unique challenges for the urologist. So lymph node involvement is the most important prognostic factor in these patients, and understanding the relevant anatomy as well as the principles of nodal management is critical to achieving the best oncological outcomes, as well as minimizing treatment-related morbidity. So Dr. Chacha will be taking us through the surgical anatomy of the inguinal and pelvic lymphatic drainage pathways, as well as the approach to nodal assessment and management in penile cancer. Dr. Chacha, you can share your slides and you can start with your talk.
Good morning, Aman. Can you see my slides?
We can. You can continue.
Thank you. Good morning, everyone. As Dr. Omar has already mentioned, I'm Groote Chacha, and I have been tasked with discussing surgical anatomy and management of lymph nodes and penile cancer. So we will go through an introduction, and then we will look at some anatomy of lymph node drainage of the penis, as well as anatomy of the inguinal nodes, and classification, as well as management and guideline recommendations when it comes to lymph node management. We know that penile cancer is rare in industrialized countries, but the annual incidence in Southern Africa is estimated at 1.6 per 100,000 men. And majority of penile cancer is SCC, which makes up more than 90% of these cancers. We also know that penile cancer has a phase of contained local regional disease before it starts metastasizing. And management of lymph node is then important in penile cancer. Skip lesions are rare, and this provides a window of opportunity for cure even in node-positive disease. We know that lymph node status is a strong prognostic factor for survival, and cancer-specific survival is at 95% if the nodes are clinically negative, at 80% if they're palpable on one side, and 65% if they are palpable on both sides, and 35% if you have fixed nodes or you have pelvic nodes. Timing of treatment is also important. It must be within the 3 months, as delay is associated with decrease in survival and higher incidence of extranodal extension. So Dr. Chindolo and colleagues looked at what impact adherence to guidelines when it comes to treatment of penile cancers would have on outcomes. Their study took place in about 12 European and American centers between 2010 and 2016. And they analyzed 425 patients, and they found adherence to the lymph node management guidelines to be at 73.7%. And they found no significant effect on progression-free survival, but there was a significant positive effect on overall survival. In their paper, they noted that most of the deviations from the guideline was from the patient request. On a bit about anatomy, the superficial network that drains the skin and foreskin comes together at the base of the penis, and it drains into both left and right superficial inguinal nodes. The deep network that drains the glans and the corpora runs within the Barks fascia to the presymphysial plexus, then into the inguinal lymph nodes within the femoral triangle. It's important to note that there is a crossover drainage between left and right, and the cancer can spread to either side regardless of the location of the primary lesion on the penis. Looking at the anatomy of the inguinal nodes, the superficial lymph nodes are found in Scarpa's fascia, that is below the campus fascia, and they are above the fascia lata. They are distributed around the saphenous vein and its tributaries as it enters the femoral vein. Its tributaries include superficial inferior epigastric vein, the superficial circumflex iliac vein, the accessory saphenous vein, and superficial external pudendal vein. The superficial nodes are then divided into 5 groups. These groups are known as Dazzler zones, and they are superomedial, superolateral, inferolateral, inferomedial, and the central zones. The central and superomedial zones are of important notice because they primarily drain the penis, and they are the area of the anatomic sentinel node. In terms of anatomy of the deep inguinal nodes, these are located below the fascia lata. They receive drainage from superficial nodes. They may sometimes receive direct drainage from the deep network of the penis, and this is an important consideration when one is opting for superficial node dissection only. They form a chain along the femoral artery and vein in the femoral triangle, and they run through the femoral canal under the inguinal ligament to drain into the pelvic nodes, mostly the external iliac nodes. The node of Cloquet is the most cephalate in this chain, and it must be marked separately when one is doing deep dissection, as this is a surrogate for pelvic node involvement. Also, one needs to be cognizant of where the femoral nerve runs and where the spermatic cord is, because these two structures can have catastrophic outcomes if injured during dissection. So once one has histology and managed the primary lesion, you then have clinically 3 scenarios when it comes to lymph nodes. You can have no palpable lymph nodes, you can have palpable mobile lymph nodes, and you can have large fixed or ulcerated lymph nodes. You can also have positive lymph nodes in the pelvis on staging CT. When it comes to management of clinically non-palpable lymph nodes, we know that up to 25% of these patients have occult metastasis. That means up to 75% of these patients would then have dissection, which is an overtreatment. So then the guidelines provide a risk stratification to when one approaches these patients. So the stratification is then low risk, intermediate risk, or high risk. In low risk patients, both NCCN and EAU guidelines recommend surveillance. And when it comes to intermediate and high risk, the NCCN suggests surgical staging with modified or radical bilateral inguinal lymphadenectomy or dynamic sentinel node biopsy. Whereas the EAU in intermediate risk suggests that surveillance may actually be an option, also with surgical staging and dynamic sentinel node biopsy, but this needs to be on a case-by-case basis. In high risk, EAU also suggests that dynamic sentinel lymph node biopsy or inguinal lymph node dissection, the recommendations. It's also important to note that patients with lymphovascular invasion or perineural invasion are not candidates for surveillance. So when it comes to surveillance, these patients must be fully counseled. They need to know the risk of occult meds, as we have just discussed, and they also need to know the impact of delayed treatment on survival, as we offset this against overtreatment and complications that are associated with lymph node dissection. The suggested surveillance follow-up is 3 monthly within the first 2 years, and then 6 monthly in year 3 or 4. And then from there, it should be annually. The dynamic sentinel lymph node biopsy is an evolving concept. It was initially based on work by Cabanas in 1992, where this was a fixed anatomical site where they noted that metastasis will first show up. This was based on lymphograms that showed consistent drainage of the penis to superomedial group of the superficial lymph nodes. However, this was associated with high false negatives, and there were positive nodes found elsewhere. Dynamic sentinel node then was to improve on the accuracy of the sentinel node. This then added a visual and gamma emission, and was found to decrease the false positives down to 18%. A further modification to the dynamic sentinel node then was with the addition of ultrasound and fine needle aspiration cytology. The ultrasound can identify nodes with altered architecture, which would appear hypoechoic and heterogeneous, and then a fine needle aspiration for cytology would be done on these nodes. Other thing noted was that metastasis can block the sentinel node, therefore rerouting lymph drainage. This would result in positive nodes not taking up radiotracer or dye, and being negative when one does dynamic sentinel node biopsy. If the cytology of fine needle aspiration is positive, then one can skip the dynamic sentinel node biopsy and just proceed to dissection. In a systematic review, they found that false negatives with this modified dynamic sentinel node biopsy can be as low as 3.5%, and in some studies, it's still up to 22%. This further emphasizes the point that this should be done in high volume centers and on expert hands. The dynamic sentinel node biopsy is, however, a compelling option because they found that the rates of complications were very low with this biopsy. So now we get to the radical lymph node dissection. The indications include non-palpable lymph nodes, but with positive dynamic sentinel node biopsy, and surgical staging in high risk and intermediate risk where you don't have access to dynamic sentinel node biopsy. And when the nodes are palpable and mobile, the radical lymph node dissection then is the standard of treatment. In nodes that are fixed and in patients that have pelvic node positive disease on scan, then radical lymph node dissection is indicated if there is positive response to neoadjuvant chemotherapy. The radical lymph node dissection was initially described by Dassler in 1948, and it's got its superior border as the superior margin of the external ring to the anterior superior iliac spine, and the lateral border is a line drawn from the anterior superior iliac spine 20 centimeters down, and the medial border is a line drawn from the pubic tubercle 15 centimeters down, with the inferior border being the apex of the femoral triangle. The base of the base then becomes the sartorius muscle, the femoral vessels, and adductor longus muscle. In this dissection, fascia staphylos vein are taken, and sartorius transposition is usually done to cover the vessels. This is just a picture from an article by Ostert and Clark, where they were describing inguinal lymphadenectomy in penile cancer. In figure 1, I hope it's projecting well, you can see the base after deep inguinal node dissection, the sartorius on the lateral and adductor longus on the medial, with vein, artery, and nerve, as well as the inguinal ligament. The second figure just shows sartorius muscles before and after rotational flap. It is important to keep the medial aspect of sartorius muscle attached because this is where the blood supply comes in. So the reason why majority of people then try and avoid radical lymph node dissections is because the rate of complications are high. In some studies, they show that they are as high as 43% for major complications and up to 70% for minor complications. These complications include wound complications such as wound infection, necrosis, and wound breakdown. The patients can develop lymphedema, lymphocele, seroma, and lymphoria. And one can have vascular complications as well, DVTs, pulmonary embolus, and neuropraxia. So the EAU panel on penile cancer guidelines then looked at what can have impact on complications to try and decrease these complications. And from their systemic review, they found that linear transverse incisions have a positive impact, as well as saphenous sparing, fascial sparing, minimal invasive techniques, and deep vein thrombosis prophylaxis as well. And sartorius transposition and vertical incisions or S-shaped incisions were associated with higher incidence of complications. So the fascia-sparing lymph node dissection then has similar borders as the radical lymph node dissection, with the difference being that the base is then formed by the fascia, and the deep nodes are only dissected just distal to the fossa, and the saphenous vein is spared. Some studies show that there is comparable oncological outcomes with this kind of dissection, with reduced complication rates when, but there has not been a comparison on head-to-head with the radical lymph node dissection. With minimally invasive inguinal lymph node dissection, video endoscopic lymph node dissection, as well as robot-assisted video endoscopic lymph node dissection has been described. And at this point, they are not yet part of guidelines. The EAU recommends it as part of clinical trials. Most evidence is on non-palpable lymph nodes, with limited evidence on palpable mobile lymph nodes, and virtually no evidence when it comes to N3 inguinal lymph nodes. And it perhaps may be more useful when one does a pelvic node dissection. So indications for pelvic lymph nodes dissection then would be a prophylactic dissection where 3 or more inguinal nodes were positive on pathology, as well as extranodal extension noted on the pathological report. It is accepted that the positive inguinal lymph nodes drain to the ipsilateral pelvic nodes. So in this then prophylactic dissection, it still remains controversial whether one should just do the ipsilateral dissection or do bilateral dissection. The external iliac pelvic nodes are the most affected, and this procedure is considered more staging procedure with limited therapeutic benefit. Clinically, Node 3 disease, pelvic lymph node dissection is recommended if the patient has responded to neoadjuvant chemotherapy. So now looking at some of our papers here and reflecting on our local experience, Dr. Jeremy and colleagues looked retrospectively at a cohort from both Devon and Pietermaritzburg between 2014 and 2019. There were 93 penile cancer patients during that time. 38 of them had palpable lymph nodes and were for lymph node dissection. And the results showed that only 23.7% had pathologically positive nodes on histology. I think it's worth noting that in this cohort, HIV positive patients made 84% of the cohort. So then if you take that into consideration, if you look at HIV negative patients that underwent lymph node dissection, then you would have a pathologically positive node rate of 33% compared to 21% in HIV positive patients. Dr. Afolayan also looked at a chart review of management outcomes of penile cancer patients who underwent penectomy over a 5-year period at St. Aidan's Hospital. This was a period between January 2016 and December 2020. There was about 89 files that were reviewed, and the median age in his cohort was 47. It's important to note that 60% of these patients were actually below 50, and 97% of them had palpable nodes, and they were noted as clinically N2 in 71% of the patients. After lymph node dissection, the pathologically positive lymph nodes rate was 43.2%. I think it's worth noting also that in this cohort, the HIV positive patients also made up 78.1% of the cohort. And there are quite a number of things that can affect lymph nodes. And from the two papers, the authors did not tell us about the yield of nodes. It also could be that because of the high HIV positive population in the cohort, that could also have an impact on the high rate of reactive nodes on pathological report. So in conclusion, lymph node status is an important prognostic factor, and time-as management is important because we know that delayed management of lymph nodes has an effect on overall survival. Although radical lymph node dissection has high morbidity, in the correct patients, it saves lives. In non-palpable lymph nodes, surveillance in low risk is advised. Dynamic sentinel node biopsy in intermediate and high risk if available. If not available, then surgical staging is advised. In palpable and mobile nodes, the radical lymph node dissection is the gold standard. One can also consider modified lymph node dissection. Neoadjuvant chemotherapy is recommended in bulky disease, and the NCCN specifically recommends that one do a biopsy of the palpable nodes to confirm that they are indeed metastases before embarking on lymph node dissection. In clinically N3 nodes, neoadjuvant chemotherapy is advised, followed by surgery if the nodes are responsive to chemotherapy. These are my references, and thank you.
Thank you, Dr. Chacha, for an excellent talk. Do you have any questions on the floor? We have a question from Dr. Opel.
Thank you very much, Dr. Chacha. I see historically with the guideline recommendations in non-palpable nodes, you obviously risk stratify them based on the primary. And initially, if it was a low risk, then you can offer surveillance, but anything higher, intermediate or high risk, obviously there's a greater chance of occult metastases. I see with the latest guideline, they say with intermediate risk, so up to T1AG2, surveillance is an option, or you can offer them, your dynamic sentinel biopsy or the modified lymph node dissection. So that's a bit of a new change to offer surveillance for intermediate risk penile cancer. Is there any role or is there any adjuncts that that we can add to surveil these patients besides clinical examination? Is there cross-sectional imaging perhaps, or any of these fancy nuclear medicine tests you're aware of?
Thanks, Dr. Opel. So the EAU states that in these patients that have non-palpable nodes, the addition of imaging does not seem to be adding more information, unless the patient then for some reason you are struggling to palpate the nodes. This would be like morbidly obese patients and patients that have been previously operated on. But from what I understand from the guidelines, the addition of imaging is not part of the recommendation.
Good. Thank you, Dr. Chacha. We've got a question in the chat from Dr. Sitilo. Says, good morning. Thank you for the presentation, Dr. Chacha. I asked for clarity on surgical staging and which type of lymph node dissection is indicated for N0 in the absence of dynamic sentinel lymph node biopsy. Just the common findings in Lusaka, Zambia, also showed low yield of pathological lymph node involvement in HIV positive patients. They attributed it to lymph node involution in HIV positive patients. Also similar findings on low age at diagnosis. Do you have any comment on that?
Thanks, Dr. Setilo. So when it comes to surgical staging, one can consider a facial sparing lymph node dissection as a surgical staging, because we have seen now that a majority of these patients would have negative lymph nodes. I know I'm not answering the question fully by saying this, but you need to have the full discussion with patients. They need to be aware of the limitations of a modified inguinal lymph node dissection as compared to a radical. And in cases where, or in institutions where one would have access to a frozen section, then one could start off with a superficial dissection, and if some of those nodes are positive, then proceed to a full radical dissection. But yes, I think the short answer would be a facial sparing lymph node dissection as a surgical staging.
Good. Thank you for that, Dr. Chacha. We have one more question from Prof. Lazarus.
Thank you, Dr. Chacha. When I was a registrar, I struggled to understand penile carcinoma, impalpable, what do you do, etc. I wish I'd heard your talk because it made it so clear and simple. So congratulations on your communication of that topic. I think that dynamic sentinel lymph node biopsy is an attractive option, and you made a good argument for why it would be favored over surgical dissection. I think many hospitals around the country will have, in fact, access to the gamma cameras that are required, gamma probes rather, because they're used in breast sentinel lymph node dissection. So the skills are often available, and we have done a few locally. But I think one thing you need to reflect on is the work from Horenblas suggested, he was the first Dutch guy to do the work, suggested a false negative rate, because that's the key. You're doing something more minimally invasive. Is it in fact going to give you the yield? And his false negative rate was around about 5%. But if you look at other people's series, they have been higher than that, closer to 10%. So perhaps this is something you need to discuss with your patients a bit more closely. Is the false negative rate with that method? But congratulations on the talk.
No, thank you very much, Prof.
Good. I think that's the last question we have. Thank you to both speakers for excellent presentations today. Just a reminder to everyone about the SAUA Congress in October. The website is up for registration and for abstract submissions as well. So please make your way to the website. Thank you everyone for joining us this week, and we'll see you next week for the next talk. Thank you.
We've only taken June, July, break. The month is next year, we're on next year. I think it usually goes for July and we skip the net. When did you stop? It stops on the 20th of June. Yeah.
How do you ask me just?
Doctor, you're satisfied with the answers to answer a question.
No problem.
So let's go through more carefully. Describe glands resurfacing.
Yeah.
So are you happy with the glands resurfacing description?
I think he was sort of on the right track with that. Glands resurfacing.
Left out one thing. What do you put when you take the lesion? What do you put there?
Oh yeah.
What do you graft?
I'm not sure. I thought it was penile skin. Yeah.
Just summarizing the lesions we have, saying the prostate.
That's usually only bladder, so there's no utilization needed, but we've had these patients who had watch circumcision, if we can use that phrase, and you use buccal mucosa, usually similar appearance, in fact, in all glance epithelium. So that's Mohs surgery. What is that?
Now that comes from skin cancer. Basically, you're going to have a histopathologist near you, and you're going to go in fine layers, done, and then as soon as you start getting a negative margin, then you stop. Sort of precision based. Yeah.
Organ sparing. Any other questions from the talk?
This thing's
So, Mark, big welcome to the division.